Well, thank you, Dr. Graham and Dr. Avara and the committee, and pleasure to hear. And I'm through this issue of kids' return to school is front and center here for the committee to consider, because as a clinician and as a researcher, from my perspective, is what we spend a major amount of time in our management of kids with this injury. I start out with this quote here from Jocelyn Elders. Those who are familiar with our public health system: "You can't educate a child who isn't healthy, and you can't who isn't educated." And it really is, we think of the yin and the yang there. But certainly, as I tell kids in clinic, we have to get you healthy in order to learn properly. And what we, of course, is that school is a youngster's major job, and that is what they to work with. And that whole process of learning new information, acquiring it academically, socially, and then doing that homework thing, practicing incompletely learned knowledge, very, very important. What does that require? That requires your brain. That requires a lot of activity, a lot of effort, a lot of exertion to do that. I like to think about the end goal of what we want in a process here in returning a youngster to school, because is a challenge. We need a prepared system. Trained medical and school providers. We heard about trained medical providers. We need trained school providers. We need to have that initial medical evaluation of the student communicated to the school system so that they know what to do with those symptoms and how to manage them. There will be that coordinated and communicated process between the family, who obviously is primarily responsible for their child, the medical provider, the school, and athletics. For that school team to be not only developed but available then to take that information, translate it properly, and manage that youngster. And as they are getting better, which these kids do, to then monitor and to adjust as the process proceeds in that recovery. That is an ideal, and that is what we need to shoot for. What is that these efforts have been undertaken in a variety of ways to date, and you know that the CDC has been active in their Heads Up to Schools. The American Academy of Pediatrics is actively working on a clinical report for return to schools. There is a collaborative that starts out of Oregon with a number of us around the country, and a curriculum called Brain 101 that is being made available. And then, as we know, we've heard already about state laws, 44 of them now. However, the minority of them actually explicitly acknowledge the inclusion of academic supports, and I would argue that we need to be sure that they all explicitly do that. As a clinician, what I see as I've worked with thousands of kids, significant inconsistency in the preparation of schools, both in terms of understanding this injury and how it plays out in the schools, as well as just awareness and knowing what sorts of accommodations or adjustments you might put in place. And what we see is that high schools are better than middle schools, are better than elementary schools. And I think our state laws have made this an issue for high schools, but it is slow in its translation down to that third grader. What I see is that, and this is, I think, where the AAP is trying to go, that there's fairly consistency in terms of medical providers really providing that help and that recommendation. And it's both the tool and too much. You know, stay out of school for weeks or months, or go back the next day. And there's got to be a individualized management process there. And then our school teams, knowing how the school nurse, how the guidance counselor, how the teacher, how the coaches all fit together. And what we know is that we've had a number of materials from the CDC. We need to implement them more consistently and more actively. Hell, that. This is a lot better than it was 5 to 10 years ago. So we're making progress. We are in sort of the gray zone, though, and we need to continue. So, again, the materials with Kelly Sarmiento here leading the charge in 2010 with our Heads Up to Schools, Know Your Concussion ABCs, and then in 2012, an even more explicit guidance with these 9 different elements here that schools could access. This is all on the web, of course, as you know, at cdc.gov/concussion. And it really helps to guide families, but it's all about implementation and having the right players In our work in the clinic and as researchers, we have been very, very interested in this question. And so, what we know is that concussion affects school learning and performance, but school learning and performance can also affect concussion recovery. It's a circular sort of thing here. What we see in our CDC toolkit for teachers, for school professionals, is these are the kind of things we want to be looking at to tell us that maybe that youngster is struggling with their post-concussion issues. And so what we have been interested in doing is studying this more explicitly. So in our research, this is some data that we are organizing to publish now. We've actually looked at kids in the elementary, middle, and high school, asking both the students and the parents about their level of concern, and it says, how concerned are you about this injury affecting your school learning and performance? These are kids that are largely seen within the first few weeks of their injury. And we see that the concern increases as you move up the age level from elementary to middle to high school. And what we see at the high school level is that over half of the kids are concerned early on, and even more of their parents are concerned early on. What we see then, too, is that we ask them the kinds of problems that are affecting them, and I don't know that there's a pointer that necessarily works. Maybe there is, yeah. Is that we see that headaches interfering. Again, the elementary school kids are reporting this, but we see it increase in the middle and high school kids with 60+% of the kids reporting headaches interfering with their learning, not being able to pay attention adequately, homework taking much longer, feeling too tired. And you can go down the line there. And what we see is that high school students on average reported 3 or over 3 of these kinds of problems. So it's just one, it was multiple factors playing out. Go to work tomorrow and take any 3 of those and ask yourself how productive you're going to be in your job. And that, for a teacher who's learning new information, is going to be a challenge. Then we ask what sorts of classes or subjects. It's important to know because different classes put different demands on kids' brains. And what we see is that one actually is math. And again, what we see is an increasing rate of these challenges as you move along. We actually asked parents and kids what their perceptions were. Interestingly, if you look down at the bottom, none, you see that parents actually say that there is a higher rate of their kids having no problems than the kids themselves. In other words, the kids are saying, I'm struggling with classes, and my parents don't necessarily know that. It's why we always ask kids and parents the question rather than just one or the other. The perspectives are important. The bottom line here is that we see these percentages reasonably high and substantial across the levels of schooling. And then what are you most concerned about? What we see here is that we look at the amount of work, returning to sports, the ability to learn. Again, all these kinds of things are used, and a third of the kids in high school and a quarter in middle school are about grades dropping. These are all the kinds of things that kids come into school around that we've got to manage. What we're also interested in is how we can actively monitor these kinds of phenomenon, and we like to think of this issue of cognitive exertion, which is anytime you're doing prolonged cognitive activity, what does that do to your symptoms? And can we manage that actively? Again, a little too much is probably not effective with kids, but instead knowing how do we meter the amount of activity. So what we did is we asked kids, do cognitive and physical demands worsen your symptoms in school? And what we see is that 62.5% of kids in the high school, 52.5% in middle, and 47.7% in elementary said that yes, over the last 2 weeks, cognitive activities and demands clearly affected their symptoms. What we see is, interestingly, the physical demands did not. And there's a little category there called no op. Said, why didn't it affect you? And they said, well, we didn't have any opportunity to do physical demands. We were managing physical activity, frankly, at a better rate than we were managing cognitive activity. Again, it's not none, it's not everything, it's how you manage that. Various ways, and I'm going to move through this in my final minute here, various ways that we can look at the kinds of problems and adjust that curriculum accordingly based on symptoms and based on any kinds of cognitive difficulties. So there are active ways that we can help. We developed, as part of the CDC's physician toolkit, a guide for returning to school and providing various accommodations. This is the ACE Care Plan that we send out with every kid, every visit, to communicate directly to the school. So, the bottom line is concussions can clearly have a significant effect on injured students' school learning. And school learning can potentially have a significant effect on those recovery outcomes with worsening symptoms. We've got to actively work with our school and school personnel in playing an important role in helping youngsters get better from this. Understanding and monitoring those students' symptoms is critically important, and tying together the family and the medical system in that is extremely important. Steps, and the way, what we know is that when we send an email out or something and it's all in caps, that usually means you're yelling. I'm yelling, folks. We have a significant need for more systematic training and service delivery and coordination for kids with concussions in the schools, and we've got to study effective treatment methods to balance, again, recovery and learning. It's too little, it's not too much. It's we go in the middle for that individual. Thank you. Ms. Brown.
Good. My name is Brenda Egan-Brown. I'm here as the program coordinator for the Pennsylvania for what's called the Brain Steps program. I'm going to talk about what we know in Pennsylvania. We regularly collaborate with other people across the nation, such as Dr. Jerry Joya, and people in Colorado, people in Oregon who are currently doing concussion efforts in their states, so that we can make sure that what we do with Brain Steps is up to the current, status of best practice. STEPS program is funded by the Pennsylvania Department of Health and the Pennsylvania Department of Education completely, and it's implemented by the Brain Injury Association of Pennsylvania and has been so for the past 6 years. Brain Steps program it serves any student with any type of brain injury that occurs after birth of severity. We have 30 trained brain injury consulting teams consisting of 320 consultants across the state. This includes educational professionals, medical rehab professionals such as Children's Hospital of Philadelphia, therapists, neuropsychologists from the Children's Institute of Pittsburgh. It also includes family members. These offer training, consultation, and support to students, families, and schools across the state. What we have seen in the past 6 years is a huge increase each year of the number of concussion referrals that we have been receiving. What we realized very fast was that for students who linger post-concussion, striking that balance between the need for rest and keeping up with academic content in school was the biggest struggle for both students and schools. So we got together with the Department of Education, who we work very closely with since they are our funders, and we created this past fall a teacher's desk reference. It's 6 pages. I have probably 100 copies here, so if anyone would like one, you can go to our website. It's a basic, what teachers need to know to manage students' concussions, especially the first few weeks. Went out across the state of Pennsylvania. Our referrals continued to come in. Any of our referrals were too early. Doctors' offices were referring them as soon as the student went in. By the time the Brain Steps paperwork got signed by the parent for permission, the students were recovered. So we said, okay, let's back and look at a process. How can we make sure that students are receiving support that they need in school? We decided to sit down and figure out what we need. So we knew that there needs to be a concussion return to school protocol, along with the return to play protocol. That is law, but the return to school piece isn't part of our law in Pennsylvania. So we are encouraging schools to come up with their own protocol for return to learn, return to school. Also, it's important that staff is trained in concussion, because when people really understand concussion, they tend to be more sympathetic and will make accommodations if they understand it. Because my generation, we learned that concussions were no big deal, as all of us here knows, growing up. Now things have changed, and we have to make sure that gets down to the teachers. Also, develop methods for gathering data This is huge. Schools can't make decisions about education, or shouldn't be, unless they are collecting data. They really need to have academic and symptom monitoring tools when students come back with concussions. Make these judgment calls. Does a student need, more intensive supports? When do you fluidly adjust the supports? Created a return to school project where we rolled out across the state through the Department of Education called Concussion Management Teams. We created a return to school protocol, and it consists of 2 people. I also have copies of this here if anyone would like it. There's 2 monitors, an academic monitor and a symptom monitor. They meet weekly. They ask each other 3 questions based on the data that they have returned to them, an academic monitoring tool sheet and a symptom monitoring tool sheet. 1 page, 1-sided. I was hoping for 50 concussion management teams. We had registration open for a month and a half. We ended up with 360 registered across the state. It's obviously a huge unmet need that the districts wanted to set these teams up. We have 80 additional that are waiting to be trained right now, and I'm sure that this just isn't a Pennsylvania thing. I'm sure that this would be needed across the United States. So our concussion management teams follow our Brain Steps Return to School Concussion Protocol, and we also gave them a concussion management toolkit. It includes teacher letters, that includes monitoring tools. We have in Pennsylvania is a layered approach. When the concussion occurs for the first 4 weeks, when schools have concussion monitoring teams in their district, they monitor the student for 1 to 4 weeks at the district level. Then 4 weeks, if that student is not better, then referral can be made to the Brain Steps program for more intensive educational support. Concussion modifiers are present, as we talked about, history of, minds, ADHD, things like that. A student can be referred earlier. Ensure that cognitive demands or schoolwork placed on a student are below the student's individual symptom threshold. And I always tell schools, this is not difficult. It's really not difficult to do. We know that students shouldn't push through symptoms because it exacerbate their symptoms. We are surmising that it could prolong recovery time. So we see front-load accommodations initially. If a student is concussed, there should be a plan in school. Accommodations should be made. Hopefully, it will only last a few days, and then the accommodations can be lifted. Hopefully, maybe it will be a few weeks. As someone said earlier, about 80% do recover within that, very short time frame. Initially, a concussion, when symptoms are severe, then gradually half-day school with accommodations. I could go on about the different things with this, but I won't. Full-day accommodations, then we graduate a student to full-day accommodations as long as everyone is on board with the accommodations. We want to make sure that student can stay in school, learn without getting a headache cycle, without becoming too fatigued. And full school extracurricular involvement without accommodations. At this point is when return to play should begin, the return to play protocol. When a student has no symptoms in school, this is when we believe they should return. Work, this is something big that we really push. This causes a lot of distress to students. What is excused and need to be completed? What is the student responsible for and must be completed? Make a list. What is graded? What is not graded? This alleviates so much stress on the parents, the teachers, and the students. It's very simple to do. Now, when students come back to school, our concussion management teams blanket accommodations initially. Again, it may only be a few days, but we want that student completely accommodated, no tests, reduced in-class work by 50%. That sounds scary. It's not scary. What we're saying is cut all repetition, make sure the student understands the key learning content for that day, and once that's mastered, don't make them repeat it 50 times, math or something to that effect. Build those rest breaks into the day. Don't have the student ask for rest breaks when they need it, because when they ask for it, it's too late. They're already into their symptoms. Instead, build the rest breaks into the day. We say about 30 minutes with about 10-minute breaks. Also, our Concussion Toolkit includes a letter where the concussion management team sits down and they go through and they can determine over time what needs to be adjusted for the student. You know, can they be excused from once per day, one taking tests, testing in a quiet or separate room. So these are very common accommodations that we find work well in the state of Pennsylvania. So let me close these. A glimpse of our academic monitoring tool that our teams use. They're sent to the teachers once a week, back to the academic monitor. This symptom severity monitoring tool based off of the ACE Concussion Toolkit. Very basic. We want to know what symptoms. We monitor it maybe 2 to 3 days a week at first to see how symptoms are. The resources that I always promote, of course, Brain Steps. And Brain 101, as Dr. J.M. mentioned, out of Oregon. And then the REAP program manual out of Colorado. And that is my confirmation. So thank you very much.
Ms. Barman.
I'm Lisa Borman. I'm the coordinator of school counseling for Howard County Public Schools, which is a school system of about 50,000 students between Washington, D.C. and Baltimore. We high-achieving school district, and our parents are very educated. So when I from Palo Alto was talking, I was thinking, we know what you're dealing with. You've heard the deal. And I have to say, when I heard the ideal, I'm thinking, wow. I think we do a reasonably good job, but nowhere near where we probably should be with managing concussions. We're fortunate to have Joya living in our backyard, so he's a great resource. But with that, you know, with demands on schools, I think that this is an area that needs more attention. So let me go a little bit before I get to the evaluation part. In county, we, our director of athletics really took the lead on this. And he pulled together the coordinator of school nursing and me to kind of develop a protocol for dealing with concussions. And about 3 years ago. And we sat down and said, who needs to know? Who needs to be trained? What materials are out there? Training. Felt like we were experts, so who do we tap into? Thank you, Jerry. Right? We call that. There to be policies. What states say about handling this? How often does training need to take place? We certainly work with our teachers in pre-service training, but how often do we have access to them after that with the other demands they have? So then our first thing is to get the evaluation of our students. So we're counting on the doctors, neuropsychologists in our area to do that. And as you've heard earlier, it can be inconsistent. Knowledge and skills sometimes is lacking, sometimes is exceptional. And I think our parents are learning to seek out specialty specialists in this area to get the answers they need. So evaluation is really key. We have procedures. What do we do if a concussion occurs during the school day? What if it occurs outside of school? Because all athletics happen during, school time. Piece is the communication, and really this is key. I think you've heard this from both of the earlier presenters. Once a concussion has been confirmed, it's critical to communicate with all people that interact with that student. The athletics director, the athletic trainer, the coaches, the teachers, the counselors, psychologists, the nurses. And this sounds very simple, but often falls by the wayside. And it might go through the sports channels, but it might not go through the academic channels in school. And so we tried to put in our decision-making process and our flow chart, who is responsible for doing what. School counselor and the school nurse are critical to the communication. And accommodations. We are seeing more of the plans coming in. But I get my share of phone calls. I got this plan that has all these boxes checked off. What am I supposed to do with that? Will it let kids take naps during the school day? You know, and so that shows me that there's really this lack of information among staff still. Use these as guidelines because sometimes we see every box checked off, and sometimes we see used more judiciously. And so some are doable during the school day, and some are more of a challenge. But we do our best to try to accommodate that student so that he can kind of ride the balance between getting better and still doing the academic work that they need to do. The accommodations that you've seen in the previous two presentations can be in school. It sometimes is teacher dependent. Where we really, I feel like where we need to focus is getting this information down to classroom teachers. The other piece with the accommodations is coming back and doing the reevaluation. Some put into place. Sometimes they are needed a few days, a few weeks, some several months. So coming back and looking at that. And what have we learned? We learned that the preventative development is key. We need to keep doing it. We use the resources we have out there. There are some really great resources. The CDC resources are well utilized. As was said, I think, by Jerry, that we do have a tendency to focus on high schools. So we've done more training at the high school level, but much at the middle and elementary. And is understanding that every case is different, so response may be different. Sometimes people feel like they need the cookie cutter approach. Okay, if X happens, if a concussion is diagnosed, then we need to do Y. And it can change based on severity of the case. So that's sort of the real life version of the ideal. I've a lot in just the short time I've been here, hearing from previous presenters. So that's all I have to say. Thank you.
Thank you. We have a period of time now for questions from the committee. Same ground rules as before. Just line up behind the microphone. We'll go one by one. And if you would identify yourself as you begin speaking.
Sure. Kevin, Sir, Medical College of Wisconsin. I actually have two questions. The first one is specific to brain steps. When you talk about training, what does that entail? Is there, the time, the commitment, the identification of people, the cost?
So the question was about how much time it takes. And this is probably a little bit unique to Pennsylvania because we have the Brain Steps program in place. And what we wanted to do with the concussion management teams in Pennsylvania was train them. They knew how to manage concussions for about the first 3 weeks. The first 4 weeks until they made referrals to us. Team members are much more, they've gone through days and days of training in general on all severities of brain injuries, but the concussion management team training is 3.5 hours. It is the Brain Steps program and also a Children's Hospital of Philadelphia concussion management doctor. And then what happens is after that initial training, they receive their concussion toolkit, and then they meet with their regional Brain Steps teams to fully implement a protocol in their district and to get the training out then to the staff. So concussion management team training, the initial training, is 3.5 hours for just the 2 monitors on the concussion management team who are the ones that are going to be implementing the concussion toolkit.
My question is regarding standardized testing, things like ACT. Are there any recommendations for what to do with that?
Yeah. Start, and Lisa, since you direct it in the county, you probably can. Every youngster obviously is different, but thinking about in particular ACT and getting through 4 hours of testing, can be a challenge. And I think we have to evaluate evaluate what that youngster's tolerance are, and can you, again, with the idea that we try to normalize as early as we can, but with symptoms in mind, can extended time and rest breaks within that testing suit that youngster? And so from the clinical perspective, we try to see if we can maximize that. A lot of kids, certainly in the first few weeks of their injury, cannot tolerate that. If they've got more significant symptoms, and others can. So it really is quite individualized. The challenge, of course, is how you get that information to the the College Board in time in order to prepare for that. And I'll give that to Lisa.
It's interesting because in preparing for this, I went on the College Board website to look at their process. And they do have something, if you dig pretty deeply into their website, about how you request accommodations for students who have concussions. But it's not easy. And they're pretty upfront on their website about telling you that you may not get those accommodations in time for the testing. And so they recommend that you delay the testing if you can't sit for that amount of time. So it's a matter of the school saying, okay, we're going to give you rest breaks during this test because, as you know, it's very carefully monitored, and you can't do those things without having the College Board or ACT approve those accommodations. I don't know the average time that it would take to get those. I know when it can be several weeks. They do say that they will try to expedite it, but they don't promise that they will.
Okay.
I have a question.
If you would identify yourself again.
Oh, I'm Al Rocker. I'm from Brown University. What connection is there between the school and the physician, the treating physician?
So we make sure that in Pennsylvania, for those people that have concussion management teams, they are sharing all of the information, the academic monitoring tools and the symptom monitoring tools with the physician, because what we saw occurring, kind of a trend going across Pennsylvania, was a lot of times physicians were returning students to play and were still needing intense accommodations at school. So that just proves that there was just no communication. And so that's how we do it. We really encourage that.
Yeah, and this really backs up to the first session, which is ultimately, what is the medical field prepared to do as it relates to return to school? I see wide variability in terms of that communication. Again, it is getting better. I am always excited to hear that there was a measured response in returning someone and giving that symptom profile. But we have a long ways to go because there's a lot of inconsistency. One of the big concerns from my perspective is actually when that youngster goes back into the school building. And on the one hand, we recommend that if you can take a day or two off just to largely measure how those symptoms are going to play out after the injury, that can be helpful. There's also been a view that I've seen that it takes weeks and weeks and weeks before you return to school, and that probably for the mass majority of kids is too long. And so, again, that measured response, we still have a long ways to go.
And my next one is, I have a lot of trouble with when I ask them to determine what is essential and non-essential work. Every teacher thinks everything they do is essential. I have a lot of trouble having people determine cutting out the repetition or cutting out what I think is non-essential. And so how are you dealing with that?
It is very difficult. Again, it's individualized basis. We look at what does the student need to know, that key concept for the day, and we always drill that down. What is your key concept? And they're like, everything. They need to know everything. No, what's the key concept according to the standards that you need to get across? And is there a different way that the student, do they have to do that report, or can they do a Civil War timeline instead of writing a Civil War report? So we really try to work with the teachers to tell them what we've seen work for other students, but that is hard, trying to cut the repetition. Math class, it's much easier. You have 50 math problems. Do they know the key concept in the first 10? Do they have to repeat it 40 more times? Probably not. That's cutting the repetition. So I find math is much easier to get the key pulled out than some other things, but
We don't have the official concussion management team. We do use a team approach, and I agree with you. Sometimes teachers don't understand, what a few key concepts are. But I found that the counselor can also often be helpful in working with the teacher. We are getting more kids coming in with the care plan, which is helpful. Just the counselor being sort of that liaison between the medical community and the teacher seems to help us somewhat.
On a system level, I was in Boston this past fall, and Phillips Andover Academy actually looked at their entire high school curriculum and established what were the critical key essential concepts that needed to be taught and this actually was unrelated to concussion. It was for other medical illness, which you could expand this to beyond concussion. To then know how are we going to, as a system, move forward. Now, obviously, there's going to be some differences depending on the youngster, but I thought that was an innovative approach of looking at our curriculum and understanding what are those key concepts to at least give that teacher a head start.
Okay, Anthony. Are you offering teachers and staff continuing education, or how are you requiring them to be trained?
For our concussion management teams, they have their professional development credits, so that kind of entices everyone to get involved. Our Brain Steps program has presented in the past 6 years to over 27,000 professionals in the state of Pennsylvania. So we are constantly out there presenting at the district level. But again, this is different in Pennsylvania because we have this infrastructure.
We currently aren't.
Nancy Temkin from the University of Washington. I really appreciate the balance between the too little and too much. I was wondering if you could share with us what do you consider to be before somebody who's recovering, in the normal maybe symptoms in 2, 3, 4 days, what then tell them about going back to school?
Well, with no symptoms in 2, 3, or 4 days, we are maximizing that return. And again, it really is all about understanding what that response is to the activity, to what extent. And the four things that we monitor closely are headache, exacerbation, fatigue, difficulty concentrating, and irritability, to sort of cover those bases of physical, cognitive, and emotional. And we actually teach kids to do that monitoring. I say it's not unlike what you do with diabetes or asthma or other kinds of chronic illnesses where you're just trying to help kids know how to self-manage, but also their parents, the teachers, that sort of thing, so that you can introduce the activity in a measured way. Certainly if somebody is not somatic when they're at a lower level of cognitive activity, then what we want to do is ramp that up to the level they can handle. But again, that's going to require a school team that is carefully monitoring that over the course of the day, and for the parent to appreciate that. And so, I think that's something that we have not yet instituted in most schools and very actively need to. At the same time, we've got to do a little bit more research to understand that as well. But that's that's our general approach clinically.
Hi, I'm Dan, University of Pittsburgh. I have a question which may fit exactly into this topic, but it seems like it would be something you would be asked, which is about return to driving. How do you make that determination?
We had this conversation amongst our team, and our team also is a multidisciplinary team, including physicians, neuropsychologists, athletic trainers, physical therapists, sleep medicine people, the whole 9 yards. We actually looked at state laws to try to understand whether there was any guidance, and all the guidance is like if you have the diagnosis, then there are restrictions. I know that in the more severe traumatic brain injury world, and I would imagine, Stan, you've had to deal with this in more severe brain injury. We have programs that evaluate someone's both cognitive and physical capabilities. I have not seen that directly applied to, for one, concussion. but two, the developing driver. And so, as we know, 16, 17, and 18-year-olds are not necessarily expert and automatic in doing this. And so we are very cautious. We counsel our families. We talk about the kinds of symptoms, whether they're pain-related, fatigue-related, reaction time-related, cognitive-related, that may be associated with this. But I'm not aware of any evidence-based guidelines at this point. When in doubt, we sit them out of the car, the driver's seat at least.
I want to add one thing. In Pennsylvania, we have one school, because a lot of our schools now are looking at their protocols for return to school. And one school in the Pittsburgh region, in their protocol, their procedures will not let concussed high school students drive to school. And it's kind of twofold. One, they don't want any accidents to occur on property. And two, it has curbed, their hope is that it is curbing any students from potentially faking concussion symptoms because they might want to drive to school. So that's
I will tell you that even with my most committed athletes, when we can clear them to go back to sports, they're very happy. When we clear them to go back to driving, they are elated. It is actually, quite honestly, it is one of the signature moments for adolescents in their return. It is their independence being given back to them. So it's a hugely important issue, but obviously a hugely challenging issue as well.
Before the next questioner, just a procedural comment here for those of you in the room. The primary purpose of the Q&A is to allow committee members to question the panelist. However, the next questioner is not a member of the committee, but it looks like we only have one other committee member ready to question, so I don't think you're going to exclude her from having a question, so no, okay, go ahead. But I thought, since this is the first time, I thought articulate the ground rules, but you do need to identify yourself.
Brady Horton with the American College of Radiology. I was curious how the coordination happens with sports not at the school, community or travel teams and for-profit travel teams.
It isn't very well. We largely ask the families, at least in our experience, to communicate that with the school because it is ultimately their responsibility. And we know that happens quite variably. We've had in school where there was no knowledge that the injury, and I know this from the athletic trainers, who are following them in their activities in school, not knowing that an injury happened outside of the school. So again, it's one of those things where for sports outside of the school, I think we really need to make a strong push that their coordination with activities inside the school become a mandatory event.
I think it's really up to the family at this point.
Gas Children's Hospital of Philadelphia. I wondered if the panel could comment on school disparities. So how are these accommodations successful in districts that are struggling with other very fundamental issues such as safety, security, getting kids to show up at school? How do you affect these communications and relationships in some of those districts, inner city and otherwise?
Well, I can give you an example. In Pennsylvania, Philadelphia, we are experiencing that because we have it's the highest volume of injuries in general occurring in Philadelphia. And our Brain Steps team was cut by half because of layoffs 2 years. So we went from 30 down to 15. And we see what we have had to do is find champions in specific schools, and that really helps. Because we need someone to own and want, like someone who really cares about concussion and gets it, and then we build from there. So it's a very slow process, but it is happening, and that's my example. We just really have to find the champions and make sure that they are trained and support them with extra.
I see the challenges that we face in a high-performing school district where parents are pretty educated about concussions, and I also see our neighboring, city schools. I would imagine this isn't even on the radar screen.
Dr. Wright and then Dr. Rivera.
Joseph Wright, Children's National Medical Center. Each stressed the need for measured and individualized approach. And I'm wondering if the formal incorporation into individualized education plans, a health component of individualized education plans, is a mechanism that is employed with each of the programs you've described to get everyone on board. The IEP obviously being a built-in and a recognized infrastructure, and I'm just curious if the IEP is utilized as a way to build in the coordination and the individualization that you have all talked about.
We're using 4 plans.
Yeah.
If the symptoms persist, we don't use that as the go-to, but if they persist, and we use a general rule, 6 months, which may be long, but that's kind of where we are. We have something informally called an action plan that we try to put into place on the IEP route.
I really think there are tiers to this, and at least historically, the IEP and more formalized special education services, and typically, and both as a former school psychologist, but somebody who also pays attention to this inside schools, the IEP process is agonizingly long, such that a youngster would not actually get services likely in time unless they had these real chronic persistent problems. I can tell you, out of the thousands of kids I've seen with concussions, I've never had one needed a formalized IEP specifically for concussion. However, 504 plans, which are more adaptable in some respects, they can suffice. They still fall within the IDEA umbrella. Then there's sort of the pre-504, which is the next day after the injury process. And I like to think of that as actually the first tier, or in essence, the gap problem. I think that's our biggest challenge, is actually that early gap problem. If a school was ready on day one to put a 504 plan in place, that would be nice. I mean, it's really about putting that action plan ultimately in place, and being able to access these formalized mechanisms if we can make that happen.
Yeah, there wasn't that gap where it gets a concussion and then to wait a few weeks to get to maybe see a concussion specialist, concussion doctor. So what do? They go back to school and they push through it. And, we, again, surmising that could be prolonging recovery. We know it's spiking their symptoms, which will impair their education, even if it's just temporary. So if schools, if we can get them on board, say, hey, just manage these concussions, we're hoping that they will get better faster, as long as everyone's on the same page, immediate accommodations are put in place. That's what they think will happen. That's where the research needs to be, I think.
Thank you.
Dr. Rara, last
question. In medicine, we've worked hard to try to decrease variation in healthcare. My perception is that there's tremendous variation in how schools deal with this problem. Should there be some of the Federal Department of Education that mandates schools to handle concussion in a certain way?
Well, the subject of the 2010 that we had with the House Committee on Education and Labor, and that was something where we tried to look at, almost in the same way that the Lystat law was looking at trying to standardize across states return to play. We were trying to look at, can we try to standardize and incentivize states to do return to school activities, which of course would build in training and all the kinds of procedures we're talking about. Again, hopefully addressing the disparity issue, and the disparity between elementary, middle, and high. The whole that since has been tabled, but I would love to see the Department of Education take that up.
I think the Maryland State Department of Education just concluded their task force and put out some findings that include something more systematic across all the school systems in Maryland.
I'd like to thank the second set of panelists for a very helpful presentation.